For our next speaker, Dr. Ashley Turner is our Chief Pediatric Critical Care Fellow here at Washington University. And I'm excited that she will be joining our faculty starting in July for neurocritical care focused PICU physicians. And so she's going to talk to us today about assessments of PICU outcomes.
Thank you, Kristen, for that kind introduction. And again, my name is Ashley Turner, and today I'll be discussing the assessment of PICU outcomes. Fortunately, mortality in pediatric critical illness has shown a steady decline over the last 3 decades, from 1 in 5 to 1 in 25 pediatric patients. However, the majority of pediatric critical care research continues to focus on mortality as the primary outcome. Despite the falling mortality rates, new morbidity is prevalent in the years following critical illness, with new morbidity or mortality noted in 1 in 5 survivors of pediatric critical illness 3 years following discharge. So as a result, there's been a growing interest on the outcomes after discharge. Maddox and colleagues from the PICU, or the Pediatric Acute Lung Injury and Sepsis Investigators, post-PICU working group, performed a systematic review of PICU outcomes publications in 2020. They identified 407 publications. 87% of them have been since 2000, so definitely a growing body of literature. But despite the increasing numbers, there's vast heterogeneity in the measures used and the time point in which various outcomes are measured, which prevents us from being able to compare one study to another. In fact, of the 407 publications, there were 366 different outcome measures used. So why is that the case? And that's because, as many of you know, the study of PICU outcomes is quite complicated. For one, we must consider that recovery coincides with normal childhood development. And also, post-intensive care syndrome is also complex. This figure, published by Manning in 2018, highlights the fact that a child's outcome depends on their baseline status, as well as organ system maturation, psychosocial development, and also the influence of the family. Ultimately, pediatric survivors of critical illness often struggle with deficits in physical health, cognitive health, emotional health, and social health that affect their long-term trajectory. With 366 unique assessments used, it's worth noting that not all assessments provide equivalent data. Assessments which are easiest to administer often give you the most basic information, and those that give you more detailed information about a patient's functioning often require time, resources, money, and trained personnel. This graph, which we created for a recent literature review on the effects of sedation on cognitive outcomes, highlights that fact. I'll be using this framework to walk through some of the most common PICU assessments today. So we'll start with surveillance scales and work our way towards more comprehensive evaluations. So first up, surveillance scales are objective, rapid, quantitative, reliable, and free. No training is needed to use these instruments. Commonly used scales include the PCPC, or the Pediatric Cerebral Performance Category, and the Glasgow Outcome Scale, which are both just simple scales of degree of disability for a PICU survivor. Slightly more complex is the Functional Status Scale, which is a cumulative score of functions of mental status, sensory function, communication, motor functioning, feeding, and respiratory status to highlight normal to very severe dysfunction in each category. No surprise that these are rapid. They're fairly easy to administer, since you can even obtain them from chart review and applicable for patients throughout the pediatric age range. The PCPC focuses most on cognitive or brain function, whereas the Glasgow Outcome Scale and the FSS focus more on overall health. They're all available free, and both the PCPC and FSS has been measured retrospectively. Next up, let's talk about self-assessments. These are, again, objective, quick, quantitative, and no personnel training is needed, but patients must be fluent to complete a written assessment. Commonly used instruments include the Child Behavior Checklist, Impact of Event Scale, Pulse State Utility Index, as well as the PEDS QL. I'm going to continue to use this type of table to walk through each of these instruments today. So first up is the Child Behavior Checklist. This is a checklist that really focuses on symptoms of various mental health diagnoses, such as anxiety, depression, attention, and rule breaking. This can be done in about 10 minutes by self-assessment and is applicable for patients over 1.5 years of age. It's available in about 60 languages, and there is a fee to use this assessment. The impact of event scale is a shorter assessment at 5 minutes for patients that are older than 8 years, and it's really looking for signs and symptoms of PTSD, focusing on domains of emotional and family functioning. Both the Health State Utility Index and the PIDS-QL are predominantly for health-related quality of life. The PIDS-QL is a bit longer, but actually can be used throughout the entire pediatric age range, which is an attractive feature compared to the Health State Utility Index. And also touches on many domains across the spectrum, as you can see in the table. They're both available in multiple languages. The PIDS-QL even has condition-specific forms so that you can compare, say, patients with brain tumors or cerebral palsy is another example. So there's a variety of different forms that can be applied. Structured interviews are next. They, again, are objective and quantitative, but slightly more time intensive, and some degree of personnel training is required. Instruments in this category include the Glasgow Outcome Scale Extended, the Vineland Adaptive Behavior Scale, or the VAPS, the Adaptive Behavior Assessment System, or the ABAS, and then the Functional Independence Measure. The Glasgow Outcome Scale Extended is just a slight kind of brief 15-minute interview that leads to more detailed categorization of a patient's disability. It focuses on social, physical, and overall health, and has been predominantly used in survivors of traumatic brain injury. The VAPS and ABAS are both looking at adaptive functioning, so they give you some information about cognition and social functioning. The VAPS is a longer evaluation at 60 minutes versus 20 minutes, and both require some degree of training to administer, but can be used in patients throughout the pediatric age range and are available in 2 languages. The Functional Independence Measure, with a pediatric version called the WUSM, can be used from 0 to 18 years of age. And it really focuses on independence of ability to complete various daily living tasks, such as self-care, ambulation, and then also a component of social and cognition. It's, again, applicable throughout the pediatric age range. And in some circumstances can be free if dependent on the circumstances of use. It's available in several languages as well. And finally, comprehensive assessments. These are, of no surprise, more time intensive and really get to more of the details of functioning within various subdomains. They exclusively require in-person assessment, and some degree of training and equipment is needed for these. Commonly used instruments include the Bailey scales of infant development, the Welsh-Lewis intelligence scales, and the pediatric stroke outcome measure. The Bailey may be well known to all of you, given it's the gold standard assessment tool for the development of infants and toddlers, and it's used widely for healthy children, but is also utilized in PICU outcomes research. It's applicable for patients between 1 month and 3.5 years of age, and takes about 60 minutes to complete. It requires a whole kit since you're observing a child doing multiple tasks to assess their cognitive, emotional, and social health. The Welsh-Lewis intelligence scale is the most commonly used measure of cognition in PICU outcomes research. It's an 80-minute assessment commonly done by a psychologist for children between 6 and 16 years. This is also a commonly used measure even in the school system to measure intelligence in normal, healthy children. It looks at several domains such as verbal comprehension, visual spatial functioning, fluid reasoning, processing speed, and working memory to create a full-scale IQ. And the PSOM is the pediatric stroke outcome measure. It's an objective measure to look at the neurologic deficits and functioning for survivors of stroke. This is a commonly performed assessment by a clinician, often a neurologist, and takes about 20 minutes to complete. So again, not all outcome measures are equivalent. Those which are easiest to administer are often the least specific. When developing a pediatric follow-up program, designing a research study, or interpreting the research published by others, it's worth thinking about what does this outcome really measure and what is the assessment telling us. Here at WashU in our pediatric neurocritical care follow-up program, we utilize self-assessments as a screening tool for patients prior to their first visit after discharge. And if concerns come up, or really for many of our patients, they go on to get more comprehensive neuropsych testing. Well, what's next for the field? We've identified a few weaknesses in the literature, being multiple instruments used, and an additional weakness I haven't touched on is very little baseline data for patients as well. So I think it's clear that a standardized approach to outcome measures is necessary. And some of you have been working on this. First, I'd like to talk about Alexis Topshin's work with, which was published in Resuscitation in 2020. She created a pediatric course outcome set for survivors of cardiac arrest with a collaboration of multiple experts in the field, as well as parents and caregivers of survivors of cardiac arrest. This group had to balance the feasibility of administration of tests, but also the quality of data, and they made the following recommendations. They recommended measuring survival at 30 days or at discharge, and then again at 6 to 12 months post-arrest. They identified brain function as an important domain and recommend assessing that with a PCPC score at baseline, 30 days or discharge, and again at 6 to 12 months. And then identified cognitive function, physical function, and basic daily life skills as being additional domains to study with various forms of the PEDS QL. So I think you can see in the work here that they really had to balance what's feasible, what can be done on a broad scale, and they made these recommendations, which will hopefully be able to be implemented broadly. Erica Fink and colleagues through Polisi's post-PICU working group have been working on a similar project. So far, they've identified 4 global domains of interest: cognitive, emotional, physical functioning, and overall health, with a specific focus on outcomes of communication, survival, health-related quality of life, and pain. And they've published these outcomes and are working together right now to think about a way to assess them on a larger scale. In their publication in Critical Care Medicine in 2020, they also published several additional outcomes that were of particular interest to families that didn't meet consensus with the entire group, which are listed here. So in summary, PICU outcomes are studied with heterogeneous instruments at variable time points, and not all instruments are the same. Standardized approach to measurement of PICU outcomes is necessary to both improve the identification of individual deficits, but also to allow the generalization and comparison of PICU outcomes data. And baseline data collection is crucial to accurately interpret outcomes. Finally, pediatric critical care research must move beyond mortality and aim to assess functional status after PICU admission. I appreciate your attention. I would love to answer any questions or take comments.